was asked to do this, I was told it was kind of geared, very fellow geared, and so that is my intention. Most of the issues that I'm going to touch on will be considerations when we're seeing these folks in the hospital, and making sure that we do everything we can to minimize the morbidity of the initial episode and prevent subsequent episodes thereafter. So let's start with the case, a 31-year-old who presents with 24 hours of unremitting abdominal pain radiating to the back with nausea and vomiting. Hopefully you recognize that as pretty much the classic presentation for pancreatitis type abdominal pain. No prior episodes. There's a low-grade fever. There's some hypotension with positional change. There's tachycardia, tachypnea. The patient's diffusely tender. And their basic laboratories, they have an elevated white count, they have elevated liver chemistries, and marked elevation in pancreatic chemistries. So, Alejandro, what would you do with this patient in the ER? Would you send this patient to the CT scanner and find out what's going on at this point? So, that's the wrong answer. We'll have to edit that part out of the video. Yeah. I didn't say you're a ER physician. So I think the incorrect answer to that is no, and I'll detail that in a little while. But obviously, as we all know, most of these patients will be put through the CT scanner, oftentimes before they're seen by a physician. And that's the incorrect management, number one, because it's probably unnecessary, and number two, it actually may be harmful. A transabdominal ultrasound is certainly reasonable because of its safety and low cost, and it may inform us of etiology. This patient has one at the bedside in the ER. It shows basically nothing. So the question is how do you manage this patient? So the way that this lecture will be organized, I want to touch on anatomy because we sort of forget about that, and in pancreatic anatomy is important for understanding the local complications that can develop from acute pancreatitis, and in some cases the cause of the acute pancreatitis, although I qualify that with a maybe because that's a controversial area. Some considerations on differential diagnosis. Should we be thinking about something other than acute pancreatitis? How do we gauge severity in that first 48-hour period? And then the interventions will be how we conclude, and then the necrosis piece / fluid collections, we may or may not have time for that depending on how long I take for the rest of this. So just as again, a reminder, the pancreas embryologically will start off as two separate buds along the endoderm, and then the ventral bud will rotate around the duodenum to form one contiguous gland, as you see here. And that will occur in those first 8 weeks of life. Why is that relevant? Well, it's because you can develop several ductal as well as glandular malformations that can predispose to acute pancreatitis or other abnormalities. The classic one that we think of is pancreas divisum, which you guys can't see, but I can. It's weird. So this would be complete pancreas divisum. So there's complete failure of fusion of the ventral duct here with the dorsal duct that is draining separately. So this is a talk on gallstone pancreatitis. The good news is that if you're one of the 8% or so of individuals who are born with this anatomy of pancreas divisum, your risk of gallstone pancreatitis should be very, very low, because gallstones passing through the major papilla should not impact much of your pancreatic parenchyma. So the classic teaching is that if you have divisum, it's very unlikely that you would have gallstone pancreatitis. So taking people's gallbladders out is probably not the correct thing to do in these types of cases. And the ductal anatomy here is nicely shown by ERCP. This patient needs rectal indomethacin, right, Joe? And it also nicely shows how gallstones, as you can see in the gallbladder coming down through the cystic duct, can typically transiently occlude the major papilla, and it's thought that it's one of two mechanisms that cause pancreatitis. One is just increased intraductal pressure in the pancreatic duct that leads to enzyme activation prematurely. The other is potentially bile acids mixing with pancreatic juice. One of those two, probably the ductal pressure issue, is the most likely nidus for gallstone pancreatitis. So the divisum issue as a cause of pancreatitis is controversial, and luckily I'm not charged with discussing that today. The other two malformations just to consider, to think about, one is a common channel. So if the bile duct fuses with the pancreatic duct upstream, I think Joe's already had a case of this in our first month here, this would be a classic cause for acute pancreatitis, and probably at a microscopic level, my bias is that this happens, we don't even realize it at ERCP much of the time, and we treat it with a sphincterotomy. But certainly the longer channels that are 5 millimeters or greater, those will oftentimes be associated with choledochal seals and cholangiocarcinoma risk, as well as risk of pancreatitis. The second fusion abnormality is an annular pancreas, which is shown here. This is usually seen in conjunction with pancreas divisum. And these are kids that will present with pancreatitis. Adults, believe it or not, can go on and not have any problems through their development and present in their 4th or 5th decade or later with pancreatitis, although the more classic presentation in adults will be a gastric outlet obstruction from extrinsic stricture of their duodenum. So the cross-sectional anatomy is important to be mindful of because, again, of the local complications that can occur from acute pancreatitis. So several critical vascular structures are immediately posterior to the pancreas. So the SMV and then the portal splenic confluence. So one of the common vascular complications will be thrombosis of these structures. There's not great data, to my knowledge, that if it's observed in the acute setting, whether or not anticoagulation affects the natural history. Many of these will go away if the patient's pancreatitis subsides, but probably equally as many will not, and that puts them at risk, particularly if the splenic vein is occluded, of sinistral hypertension, gastric varices, and then bleeding from that, either into pancreatic necrosis or into the stomach potentially. Arterial structures, probably better shown on this coronal cut, which would show the splenic artery, again, running alongside the body of the pancreas. And so this is patients that have acute pancreatitis and then present typically 4 to 8 weeks or later with oftentimes a catastrophic presentation of shock, essentially. And what happens there is they develop pseudoaneurysms of branches off of that artery and bleed into their pancreas, which is known as hemasuccus pancreaticus. And these patients will not present oftentimes with GI bleeding. They'll just present again with hemorrhagic shock. The other depiction here that is also important to note is that there's a lot of vascular redundancy to the pancreas. So ischemia as a cause for acute pancreatitis is pretty uncommon. So you don't typically see people that have hypotension from any number of causes then present with acute pancreatitis. It's a fairly resilient organ to low blood flow initially, but in the setting of pancreatitis, it becomes highly susceptible to injury, which is why there's a lot of talk about fluid resuscitation. Once the inflammation sets in, it doesn't have a lot of compensatory mechanisms to compensate, like other structures like the liver. So the definition, pretty clear cut, and I'll kind of go through this quickly, but again, it's the abdominal pain. It's usually epigastric, radiating to the back is the classic story. The onset is typically minutes to hours, but oftentimes it can be more of a subacute type of presentation. The labs in conjunction with the right history is usually sufficient. And so the question I had asked Alejandro was sort of rhetorical. I mean, that case presentation that I gave you is pretty much classic. You have a diagnosis of acute pancreatitis without the need for any imaging. But of course, in this day and age, we oftentimes have radiology that accompanies patients. It is important to note that the CT scans, particularly if they're done too early on, may be normal in a significant minority of individuals. So a normal radiographic scan does not necessarily rule out acute pancreatitis. So gallstones and alcohol are going to comprise 3/4 of the causes for acute pancreatitis, which is why gallstones is the topic for today. People with alcohol acute pancreatitis will usually have some evidence of chronic change on their gland, although not necessarily. Anatomic abnormalities, there's a nice paper in the Blue Journal in the last few months from St. Louis that showed an increased risk of pancreatic cancer seen in individuals that present with acute pancreatitis, and so it's probably it's certainly something to consider, particularly in an older age population, even in the presence of a normal scan. Stones, these would be stones in the pancreatic duct, mucus plugging from IPMN, pancreas divisum and SOD are highly controversial, and so I don't think they should really be, they should be italicized, or they should be like, they should have some sort of animation that makes it clear that they're controversial, basically. Drugs, I've added GLP-1 mimetics, so the newer diabetic class of medications, again, somewhat controversial. There's mixed reports of this in large registry studies, but there is probably an association with these as well as statin drugs that should be considered. But overall, drug-induced pancreatitis is really poorly understood. It's usually kind of considered an idiosyncratic phenomenon, but it may be more than that. And then other things such as autoimmune disease, of course, Ercp, which will never happen now that Joe and I have started. Genetic predisposition, again, ischemia is very rare. Despite all those causes, you still have a substantial number of individuals that have no clear explanation. So consider other causes for abnormal amylase or lipase. I think the two big ones to highlight here are going to be patients with cholangitis or other biliary pathology, as well as complex intestinal pathology, particularly penetrating ulcers of the duodenum. So if you are suspecting those, you would be incorrect to call them acute pancreatitis. Many times we label them that, but in fact it's just rip-roaring cholangitis that causes a secondary rise in these chemistries. But because there are more sort of esoteric causes of amylase elevation, both tables, lipase is going to be a more specific test. So if you see an elevation in lipase, it is more likely to be pancreatic in origin. And then patients oftentimes, as you know, will present several days after the onset of their symptoms. And so you should be mindful of the fact that their pancreatic chemistries may normalize, and it's still acute pancreatitis. The advantage of lipase is that it hangs around typically longer. So if patients present 3 days into their symptoms, you may still capture lipase elevation, but the amylase may have normalized by then. And so for that reason, lipase is a more sensitive test. There are some reports, although I must say I've never used it clinically, that a disproportionately elevated amylase can be more suggestive of gallstone pancreatitis. I've not really seen that in clinical practice, so I don't really use that necessarily as a marker of diagnosing gallstone pancreatitis. So what obviously we do use is liver chemistries. So I think this is going to be the first major clue to etiology, particularly in a non-alcohol user. Alcohol can confuse things because obviously it can be its own cause. Of the 4 major liver chemistry tests that we'll check, the best is going to be your ALT in terms of its positive predictive value, and it's more than 3-fold elevated. But they're all fairly good. So I think if any of these are 3-fold elevated, I think you should certainly consider gallstone pancreatitis high on the list. And I'll show you some evidence to support that shortly. The second is imaging. So transabdominal ultrasound is a great test in general for gallbladder stones because the gallbladder is typically more anterior in the abdomen compared to the pancreas and the common bile duct. So its performance characteristics for identifying stones is quite good. But as you know, you take a transducer and you shove it into someone's abdomen while they have acute pancreatitis, the patients aren't going to tolerate that. So as a result of that, as well as probably inflammation in the abdomen, the sensitivity is actually a lot lower. So in that case presentation I gave you at the beginning, where the transabdominal ultrasound did not show any gallbladder stones, I wouldn't necessarily say, well, this is not gallstone disease. So be cognizant of that. And of course, I think we all know that it's really a poor test for common bile duct stones. If you're lucky enough to see one in a very thin individual, then it's usually accurate. It's usually pretty specific. But the absence of it certainly does not rule it out, nor does the absence of biliary dilation, which can sometimes take several days to develop in the setting of acute pancreatitis. So more expensive but vastly superior tests that are less invasive than Ercp for diagnosing common bile duct stones would be Mrcp and endoscopic ultrasound. Endoscopic ultrasound in the duodenum will be within millimeters of the common bile duct. And so it is highly sensitive for common bile duct stones, probably the most sensitive test for common bile duct stones, although you do have some question of specificity with it because we can have air artifact and so on, and we may falsely call a gallstone when one is not present. But the other advantage of EUS, other than the fact it is that I do it, is that you can convert the patient to an Ercp at the time if you see one. So these are clearly going to be preferred tests to Ercp, which historically has been considered the gold standard. The sensitivity of Ercp cholangiography, just injecting, is actually probably only around 80%. It's a lot higher when you do a sphincterotomy and sweep a balloon through. But obviously, you then expose the patient to the risks of Ercp, even with all the prophylactic interventions that we have now with drugs and stents. So an important take-home message to drive home is that for patients with gallstone pancreatitis, it's important to diagnose them in that initial presentation because you can drastically affect their natural history. Some of you know that recurrent pancreatitis is an area of interest to me in research. And patients with biliary pancreatitis should be at the lowest risk of a recurrent episode because we're usually fairly good about taking their gallbladders out and clearing their bile duct during that initial presentation. But as you get older, and it's probably a comorbidity and perhaps reluctance to do more extensive testing, even with biliary pancreatitis, the risk of recurrence increases to what I would argue is still a pretty unacceptably high number. I mean, 20% is still too high if you go forward, up to 10 years later. So hence it's important to recognize this as a diagnosis. So cholecystectomy, it goes back now to this question of labs and stones seen in the gallbladder. So if you look at, this is a retrospective cohort study of patients with acute pancreatitis who then underwent cholecystectomy. So if you have a patient that has both gallstones in their gallbladder and abnormal labs, take out their gallbladder, their likelihood of recurrence is pretty low. If they only have labs, numbers are small there, so there's a bit of a caveat. But if they only have the labs, meaning the threefold elevation in liver chemistries that normalizes within those first initial days of their acute pancreatitis, they still do fairly well. You actually have a little bit of a weaker performance if you just see gallstones without labs. And that's probably because of the high baseline prevalence of gallstones in the population. But they still do fairly well, so it's still reasonable. But if they don't have either and you take their gallbladder out, you're really not helping that individual. So I think many times we see patients, you scratching your head as to what happened with them, and then the clinicians will take the gallbladder out, and that's probably not the correct thing to do based on this. Similarly, if you look at Ercp, and these are patients who were considered poor operative candidates, very long-term follow-up. So if cholecystectomy is not an option, but they have gallstone pancreatitis clinically, if they get an Ercp, their likelihood of a recurrence is actually half. And that's with or without a sphincterotomy, and that's probably because, at least in this older study, you clear the bile duct of having common bile duct stones just by doing cholangiography. So Ercp is a reasonable surrogate, basically, to cholecystectomy in people who are poor operative candidates, cirrhotics, otherwise abdominal catastrophes, and the surgeons are not comfortable with it. It's a reasonable surrogate, probably with a sphincterotomy, I would argue. So the question comes up with gallstone pancreatitis to talk now about when do you suspect a bile duct stone, and this has come up with, Joe and I have talked about this now with this recent JAMA paper, which I won't get into the details of because it's beyond the scope of this topic. But when you're seeing a patient on the floor, if you've decided that they have gallstone pancreatitis, the next question is do they have a common bile duct stone, and how do you manage it? If the probability is low, and I'll detail how the ASGE at least defines low probability, there's no reason really to put them through Mrcp, endoscopic ultrasound. It's certainly reasonable to do a cholecystectomy, and one could argue not even doing an intraoperative cholangiogram, although with gallstone pancreatitis, they should. Because none of them are low probability. They're all going to be at least intermediate probability. If they're intermediate probability, which is oftentimes where many patients fall, and this is very much a gray zone, if you have a good laparoscopic surgeon, they can do a laparoscopic intraoperative cholangiogram and even remove the stones from the bile duct, and we'll hear more about this on Wednesday at the Wednesday conference with Joe and Katie. However, if they do a lap IOC, they can't get the stone out, then you do a postoperative Ercp. The alternative method to this, if you're in a facility where you don't have surgical expertise, would be to do EUS or Mrcp, and I would argue EUS because of the advantage of being able to convert to an Ercp in the same sedation as needed. So you would manage according to the result of that. And then if it's high probability, I put this in red because the ASGE recommends a preoperative Ercp, although again, if you're in a really expert center and they have a gallbladder that needs to come out and the surgeon feels comfortable, it's still not unreasonable, in my opinion, to go laparoscopy first because it's fairly low morbid, and then do Ercp as rescue and try to spare them a second procedure. So how do you characterize your level of suspicion? So if you have a very strong predictors, obviously if you see a stone, if the patient has ascending cholangitis, or if they have more substantial jaundice, so a bilirubin more than 4. If they have any of those, then they would fall in that high probability category. If they have both of these strong predictors, so a dilated bile duct in the absence of a prior gallbladder resection or mild elevation in their serum bilirubin, they would also be high probability. If they have anything else on this slide, including gallstone pancreatitis, you are obligated, they're intermediate. So basically the message is you should clear their bile duct in some fashion. So I think it would be inappropriate for a surgeon to just do an intraoperative cholangiogram if you haven't done some superior imaging to CT and transabdominal ultrasound prior. And that's basically highlighted here. So that would be an important message to the surgical consult. Yeah, so I should qualify this. This is the ASGE guidelines, which there's not, and I think Joe's going to publish something on validating essentially this, but it's all about trends. I mean, that's absolutely right. If they come in and then it comes down dramatically, or if it's going up, would be the contrary argument. So in my opinion, it's a trend component.
All gallstone pancreatitis patients, there's no dispute that at some point in time there's been a stone in the bile duct. The question is there still ongoing choledochal lymphasis, or that spontaneously passed, which happens in 80% of patients. And so a patient that comes in at 4 and is at 5.5 on hospital there 8 hours later is probably different than somebody who comes in at 4.2 and the next day is feeling much better and has a bilirubin of 1.8. And so I have always been super convinced that the failure of the ASG guidelines is that there's actually no room to sort of explore what happens in the first 8 hospital hours. Ascending cholangitis is different. They can go straight to Ercp, but everybody else often is there for at least 8 hours, has a second set of labs, and the guidelines are completely silent about that. So if you don't mind interjecting, what we did at the University of Michigan is we sort of looked at a 6-year experience.
I'm going to sit down.
In this context, and looked at what the performance characteristics were of the ASG guidelines, which was basically pretty poor. And then we looked to see if waiting on the second set of labs changed our ability to predict. And my hypotheses were that they are poor and that the trend is critical. You know, like the trend, I felt like I was always right if the trend helped me. And we found that the trend was also basically as useless as the original criteria. Which brings up the question of whether or not it would be more clinically and cost effective to just argue that in the absence of cholangitis, straight up EUS plus minus Ercp is the way to go in every single case. And there's a randomized controlled trial that was published in GIE from the Prince of Wales Hospital that showed that particular approach to be superior, or equivalent in terms of clinical outcomes, but saved a lot of complications and actually saved procedural time.
Now your study was not gallstone pancreatitis exclusively, correct? It was just all comers.
The subgroup was gallstone.
Right.
We didn't see any, I mean, a small subgroup, so limited power, but we didn't see any difference between suspected choledochal lymphasis and the subgroup of gallstone. I'd like to actually reproduce those data here just to see if it's generalizable.
Yeah, and it's worth also mentioning that any cause of acute pancreatitis will cause compression extrinsically of the biliary tree, some abnormal liver chemistries, which is why there's that threefold elevation to try to improve its performance characteristics in predicting gallstone as opposed to any cause for acute pancreatitis. But I think a lot of it depends on beyond 8 hours. My bias is really more 72 hours to see if they're going to declare themselves as being more severe or mild acute pancreatitis. Yeah, that's coming up, right. So let's talk about CT scanning, because this is sort of a pet peeve of mine in terms of where it helps us and where it doesn't. So obviously there's a variety of manifestations from nothing, as I mentioned at the beginning, to just diffuse or focal enlargement of the gland. You get stranding, which is a considered inflammatory change. Then you can develop fluid collections and, of course, necrosis, and that's basically considered a spectrum. First of all, one thing that comes up is that radiologists seem to oftentimes read necrosis in the absence of intravenous contrast, which is not possible. It can be implied by air in the pancreas without contrast, but you really need intravenous contrast in order to confirm the presence of necrosis as being non-viable tissue. Most patients that present will not develop necrosis for the first 72 hours at least, so the patient that came into that ER that we started with, their CT scan may be normal or be very bland, but then 72 hours later could have more than 50% necrosis. So it doesn't, that first 24-hour CT scan is usually pretty unhelpful in predicting the severity of course. And this is a real patient that I had in Indiana that highlights this. These were outside hospital filmed initially. Basically came in with acute pancreatitis, classic story, has a CT scan, and I think most of us that would look at this, considering that these are non-contrast films, but this doesn't look like, major catastrophe. Could be anyone it could be someone who leaves the hospital 3 days later. But then the patient gets worse, and now you can see with a crummy phase arterial contrast there, but you can see that the tail is bright, and then the rest is not. And this is 3 days later with necrosis, and then he basically crashes, and this is when we get the phone call when they have basically now shock from infected necrosis. You can see air in the pancreas, and then that patient had to go for a percutaneous drain because they were so unstable. So the point there being that day one CT scan really didn't help you determine that was going to happen by any stretch. That being said, when you have a delayed CT, it actually correlates very nicely with outcomes. So I think the classic index that most people use is the Baltazar Index, where you basically get increasing numbers of points for each of the features that you see as you work your way down to increasing necrosis. And this nicely correlates with mortality. This is older data, but I think it still applies. Hopefully all of these bars are lower than they were from the 80s and 90s where this data was derived. But the point being is that when you have a higher Baltazar score, your mortality goes up substantially. So it is an informative tool to assess for local complications as well as to assess for severity, but it's really worthless in the first 24 hours. The other point to make is that the IV contrast, there's some evidence, albeit weak, that it actually may worsen the course of pancreatitis by essentially precipitating renal failure or even possibly further vascular compromise to the pancreas. So not only does it not help you prognostically, it also may hurt the patient. And so non-contrast CTs don't tell you about those local complications such as necrosis very well. So it's also, generally speaking, not helpful. I think if you have a patient and you're worried about a bowel catastrophe, a perforation, a penetrating ulcer, et cetera, if they really have something that's atypical about their initial presentation, it's reasonable to do this. But I would give kind feedback to the ER if you get a call on a patient with that classic story, then they tell you they ran them through the scanner. I'd say, I probably wouldn't have run them through the scanner just yet because I think it's reasonable to sit on them for a little while. And so I've highlighted here, I think, as a point of emphasis when I would do this in those initial settings. So how do you assess for severity? Most of the time this is pretty obvious. You're just looking at the patient and they can't make eye contact with you. That's probably one good indicator because they're hurting so bad and they're just so sickly, or they're intubated already. The basic clinical risk factors to consider would be people that are older, that have underlying comorbidity, The obese, probably because of their visceral fat, that it serves as a great medium for more inflammation and necrosis. People who've had this is their first episode, and having an unknown etiology and then a rare genetic subgroup, which we don't check for this. These are going to be the things that would increase, associated with an increased severity. The revised Atlanta classification, which came out last year in gut, basically kind of subgrouped severity based essentially on organ failure. So if you don't have organ failure or any local complications, you have mild disease. No kidding, but that doesn't really help you when you're seeing someone day one. If they have organ failure but it resolves within 48 hours, or they have local complications such as a pseudocyst or walled-off necrosis, but they have no organ failure with it, then you would call that moderately severe. And if they have persistent organ failure, single or multiple, then you would call them severe. I'm not so sure I agree with this because the delayed morbidity of something like walled-off necrosis is pretty substantial. So if you tell someone they only had moderately severe disease, but then they need 6 endoscopies or an operation to fix their sequelae, I think that's pretty severe, but I digress. Two tools that I think are useful. There's a lot of scores out there, Ranson's and the Marshall Organ Failure Scale, Apache, and so on. These are things that you'll never use at the bedside. But two things that I think are useful. One is SIRS. So you all know SIRS, so I'm not going to go through what the criteria are for it. The majority of people with acute pancreatitis will have SIRS, so 62%. However, if you look at if they have all 4, and I think I made a point of expressing this on that initial case presentation, if they have all 4 SIRS at the time of presentation, this is a nice, I thought, cohort study. Look at the outcomes are much more substantial. So that should at least raise your eyebrows saying this person, might be quite ill. Again, it's same as the trends in the bilirubin. A lot of times this is something and they come in and they're in a lot of pain. That may prompt a lot of the SIRS criteria, and then 24 hours later, they've lost them. But be that as it may, it's something that's very easy. You have all those 4 criteria to consider, and so this should at least raise your awareness. Not that there's anything we can do about it, basically, but it's still nice to know. The second is BISAP, which is another score. This is by the Harvard group. The big one here being BUN, which again is something that we check in our usual Chem 7s on everybody, but we historically have not really paid very close attention to it in pancreatitis, and we probably should. You basically get 1 point for each of these factors. So if your BUN is markedly elevated, if you have mental status change, if you have SIRS, so 2 out of the 4, if you're older, and if you have a pleural effusion. And if you look at that, if you have all 5 of those factors, your mortality is substantial. Whereas as your BISAP score decreases, your mortality is lower. The second BUN component that's worth pointing out is how it changes in that first 48-hour period. And this probably reflects 2 things. One is how much fluid sequestration is occurring in the abdomen in people that are really inflamed. And the second potentially being that inadequate volume resuscitation and their BUNs increase as a result of that. But if you look at the BUN trends, the people that end up dying are the ones in who the BUN increases in that first 48-hour period, whereas if it goes down, it does not. And so that kind of leads us to the management issues. So I would pay attention to that BUN and certainly follow it in those first 48 hours, because that may be an interesting clue, if nothing else, to tell the patient that this is we're observing this and stay tuned essentially. The 4 management issues that I'll touch on, fluid resuscitation, which is the big one, nutrition, so feeding, when to restart feeding in people that are recovering from pancreatitis, and then how to feed people with ongoing severe pancreatitis. When do we use antibiotics, and then when do we do ERCP in the inpatient setting? So fluid resuscitation, we've been talking about it for decades, and despite that, the evidence is not super strong that it actually makes a great deal of difference. But the basic principle is that people are in a hypovolemic state. They haven't been eating because they have acute pancreatitis. They develop relative hypotension because of the inflammatory shock that's occurring systemically. And so they develop a sepsis-like syndrome. And as I mentioned at the beginning, the pancreas is not very good at compensating for that and maintaining its vascular supply. And so it's thought that despite increases in cardiac output in the shock setting, the pancreas is not benefiting from that because it can't vasodilate and perfuse itself better. So that's the basic principle. There's also some old studies, which I've now removed from this talk, that essentially showed that if the hematocrit is elevated at presentation or remains elevated in the first 24 hours, those are the folks that go on to die from presumably necrotizing pancreatitis. These are two more recent studies that I thought would be more timely to talk about because they're thought-provoking and I think very interesting. One was looking at, this is from Dartmouth, looking at all patients that they admitted with acute pancreatitis, and they basically divided their pancreatitis population into the people that got the bulk of their fluids in the first 24 hours, which they called the early resuscitating group, and then the others who got the bulk of their fluids later in their hospital course. And I put here the fluid quantities just to give people an idea of how much fluids we're talking about. So in the early resuscitation group, you're essentially talking about 3,500 mLs, which, you know, for a 100 kilo person is, if you do the math, let me see, I did this, it's about 150 mLs per hour in those first 24 hours, I think. Actually, maybe less than that. It would be for a 70 kilo person. In any event, the early resuscitators, so the people that got more fluid in the first 24 hours, if you looked at the presence of SIRS at 72 hours in the people that got early resuscitation, it was significantly lower, relatively small numbers here. And if you looked at organ failure, which is the other big kind of marker of severity, significantly lower. Obviously, it's a retrospective study. You could argue that, well, the people that started getting sicker in day 2, day 3, people started hammering them with more fluids because they weren't getting better, and so that, you know, it was a consequence that put them into that late resuscitation group. But to my knowledge, this is one of the stronger studies advocating for early IV fluids, and lots of them, basically. What is adequate fluid resuscitation? This is from the AGA guidelines, and then I'll talk about the type of crystalloid on the next slide. Crystalloid is, generally speaking, preferred to colloid. The exceptions would be if someone is very hypoalbuminemic or anemic. And we don't pay attention really enough to urine output as our marker of how we're resuscitating people. We really should probably have every acute pancreatitis patient in that first 48-hour period on a strict I&O to see how much fluid they're putting out. But generally speaking, 35 mLs per hour in terms of urine output would be considered sufficient. And these are all based on small studies. There's a lot of interest in lactated ringers, as well as having goal-directed approaches to fluid resuscitation, if nothing else, to be more scientific about it. There are now 2 studies, this being one for all causes of acute pancreatitis, and then a second, more recent study of LR versus non-LR for attenuating the course of post-ERCP pancreatitis and preventing post-ERCP pancreatitis. The thought is that lactated ringers may have, because of its acid-base properties essentially, may have some favorable benefits at the cellular level. This was a study, it's amazing, it was a 40-patient but a 4-arm study, so it's very confusing to follow. But basically, half the patients got goal-directed therapy. So they got 20 mLs per kg bolus and then 3 mLs per kg per hour for the first 8 hours. So that would be, for a 70-kilo person, 210 milliliters per hour. And then if they're fluid responsive, and this was based on SIRS criteria, they were dropped down to a more kind of typical maintenance rate, or they kept going basically through that first 24-hour period. And basically, if you looked at goal-directed versus just standard clinical judgment, how much fluid to give, the amount of fluid that people got was not drastically different. And it didn't so much matter if you did goal-directed fluids versus standard fluids, but what did matter is the lactated ringers versus normal saline. If you look at them at 24 hours, the number of people that have SIRS, the LR group looked a lot better. Very small study, but I think a larger study is forthcoming. In fact, I think they are submitting a U34 to look at that. So basically give lots of fluids, but we really need to do a better study of that. The big issues, of course, with pancreatitis is that places like this, we're seeing patients that are oftentimes 5 to 7 days into their course or later, and so it really is more for, I think, the frontline hospitals who see these patients typically in the first 72 hours to manage them accordingly. So with nutrition, the first thing I would think about, the reason I spent some time talking about severity is that if you see a patient and they're really looking like they are not going to be better within that first 7-day period, you should really have a nutrition plan in place pretty early. So considering that they're unlikely to be eating. The options, the standard options now are enteral feeding, which is typically considered beyond the ligament of Treitz, although that's controversial, and then TPN. In a nutshell, enteral feeding is going to be better than TPN, primarily because of reduced infection, line infections being the big one. There are some physiologic foundations for enteral feeding. It's thought that by stimulating the gut immune system, that may help with the healing of the pancreatitis. But practically speaking, the main benefit, I think, is in a reduction in line infections. And so certainly at a place like this, we should be pushing enteral feeding first. So then you get into what type of enteral feeding do you do. As we all know, nasojejunal tubes are a pain in the rear. They're a pain to put in. They clog, they kink, they get stuck in people's nares. Bizarre. And so they're difficult. They're the bane of many of ours existence in getting them to be deployed. Nasogastric tubes are very easy, so they're very attractive. There have been 3 randomized controlled trials, only involving 157 patients. I actually participated in a large effort that was NIH sponsored that unfortunately just died a miserable death as a study because of inability to recruit that was trying to answer this question. But be that as it may, in these 3 studies, there was basically no difference in the major outcomes. So death, actual tracheal aspiration, which is one of the major theoretical concerns of nasogastric feeding, was actually higher in the nasojejunal group. Pain exacerbations, the ability to achieve their appropriate energy balance in terms of caloric intake, these were all pretty similar. So the general feeling is that nasogastric feeding is probably okay. The one exception being people that have a mechanical issue, so much inflammation that their stomach is compressed. So we should probably be using nasogastric tubes more liberally, although we don't. In fact, I just told Robbie I didn't practice what I preached. So what about prophylactic antibiotics? I'm going to make this short because basically this is a lot of studies have looked at empiric antibiotics to prevent infection or to prevent necrosis. And the bottom line is that there's been, I think now, as many meta-analyses as there were primary studies of it, but essentially no differences. If you look at people with severe acute pancreatitis, no differences. The one caveat being that people that have necrotizing pancreatitis, the use of imipenem, which has better pancreatic penetration than, and the other penoms like Mrcp, there is a significant reduction in infected necrosis. And so I think it's always hard when you have someone who is, in the ICU, they have several organs down, they look like they're in septic shock, but in fact it's all just severe acute pancreatitis. It's very hard to withhold antibiotics, but essentially there's really no evidence to support their use empirically. And then, what you run into is that you run into more resistant bugs and fungal infections if you give them broad spectrum antibiotics for too long. So if you are going to do antibiotics, so let's say they have extensive necrosis, it should be a penem, and it should be for a defined course. The studies that looked at this were for 21 days. But generally speaking, with the ability now to sample necrosis and intervene upon it, we generally speaking, I think, advocate to withhold antibiotics unless overt infection is documented in some fashion. So the last management question is early ERCP. When do you have to address the bile duct? So we talked already, I think, at some length about proving, first of all, that it is gallstone pancreatitis. And I think labs and gallbladder stones are going to be your biggest clue. If the ERCP were easy and harmless, I think the conversation would be very different. But it's harmful. potentially. And it's actually technically quite difficult in the setting of acute pancreatitis. On the left is what left to you is what a normal papilla would typically look like. You typically have a fair amount of space to work in to cannulate. The duodenum is usually quite inflamed. The papilla can be difficult, if not impossible, to recognize. And so when you start to probe with wires and catheters, this is when you can create false tracks, and you can actually, your risks of causing more problems increase. So that's one caveat. Not that I'm chicken to do it, but the second is does it really help? So early ERCP, as the radiation oncologist, 5 days of radiation, 2 days break, 5 more days of radiation. We always say 72 hours as early, because if someone comes in on Friday night, it can still theoretically wait until Monday morning, and that's how most of the studies have been done for quote-unquote early ERCP. Similar to the issue of antibiotics, a lot of randomized trials, most were underpowered, but if you combine them in a meta-analysis, no mortality benefit of intervening for run-of-the-mill early gallstone pancreatitis for mild or severe disease. The one benefit is complications. So if the patient has cholangitis, there is clearly a role. And that also can be difficult to distinguish cholangitis plus acute pancreatitis versus just bad acute pancreatitis with biliary obstruction alone. And so usually I think most of our practices is to intervene if they have elevation in bilirubin and it remains elevated after that 72-hour period and they have severe disease. But if they're getting better, then we go back to that issue of how do you deal with, how do you prove that gallstones are in the bile duct and intervene upon them, and I think that's where you have that conversation with your surgeon about laparoscopy and so on. So it's really only for severe gallstone pancreatitis. So I have more on local complications, but I might stop and we can field some questions, and then we can go over the fluid collection components later. The main take-home points is to be mindful of patients with potentially severe pancreatitis early. Number one, to inform the patient and their family that they could be in the hospital for a while. I think that's one thing just from a quality of care standpoint, even though we don't have pharmacologic interventions yet to utilize in these patients. Hold off on getting a CT scan in that first 72 hours, and I think it's reasonable to give friendly feedback to ER docs that it may be harmful and it's really not helpful in that first 3-day period. I think standard of care is to be very aggressive with volume resuscitation, but hopefully I've expressed that the data are fairly weak on this and that we need to study that better. Consider nutrition early. So if patients are getting better, I don't think this many times, I'm not sure if it's practiced here, but it certainly was in Indiana and elsewhere, where the patient gets a clear liquid tray, and then if they're doing okay, they go to a full liquid tray, and if you got to it, or it's two trays later, basically like 2 days can go by before they get a solid tray. And these are not patients that are recovering from postoperative bowel ileus, and that would be how those patients are managed. I think if the patient is getting better, you give them food and you see what happens, basically. And I removed a small study that basically showed that if you do that, your likelihood of flaring their pancreatitis back up is not any different than if you go through that algorithm. So if it's mild pancreatitis and they're getting better, just start them on a low-fat diet, probably because it'll be faster gastric emptying and easier on their stomach, and you'll shorten their hospital stay. If they have severe pancreatitis, we should certainly be pushing enteral feeding. The standard is still nasointestinal, nasojejunal feeding at this point, but I think we should be more comfortable with nasogastric, particularly for ICU patients where the aspiration risk is low, but even for patients that are on the floor with severe pancreatitis. Try to minimize the use of empiric antibiotics, and then ERCP is really limited to patients who have severe pancreatitis with biliary obstruction, obviously concomitant cholangitis, and once they've recovered, if you've determined that they have a common bile duct stone, it should be removed, most likely by ERCP.